So it's my pleasure to introduce our speaker for the evening, and that's Dr. Abe Alexander. He's a radiation oncologist at the BC Cancer Agency, which is right here in Victoria on Lee Street. He specializes in the treatment of prostate cancer, brain tumors, and gynecologic cancers. He performs brachytherapy for prostate and gynecologic cancers, and he's involved in teaching and in cancer research. His topic tonight is reducing radiotherapy toxicity with Space OAR Hydrogel. I'm going to be interested to hear what that is. Spaceships, maybe? I don't know. So please welcome Dr. Alexander. He's been a speaker many times.
Thanks a lot for having me. I appreciate the opportunity to come back and chat with you guys again. I'm just getting over a virus, so if I have a coughing fit or a sneezing fit, I apologize in advance. My talk today is called Give Me Some Space, and the reason that's what it's called is I'm talking specifically about a special gel spacer that we're now using to help reduce side effects from prostate radiation treatment. Sort of a new program that we have now at the Victoria Centre, and so I wanted to tell you about it also in particular because this program sort of got started along with the help of the Island Prostate Centre as well. So here's the topics I'm going to talk about tonight. I'm going to just start off and just reiterate some of the issues around the extent of the problem of prostate cancer in Canada, how common it is, and the mortality rates associated with it. Talk a bit about what the standard treatment options. I'm just going to touch briefly on the various standard treatment options, and then the bulk of the talk will be about external beam radiation treatment, which is one of the 4 standards. And specifically, I'm going to talk about some of the side effects that can happen as a result of external beam radiation treatment, some of the strategies that we use to reduce the side effects, particularly side effects to do with the bowels and the rectum. And then the remainder of the talk will be about this new program, which is this product called Space OAR Hydrogel, which we're now using to help reduce some of these side effects. So to put it into context, prostate cancer, as all of you guys know, is very common. You know, it's the most common cancer diagnosed in men if you exclude sort of the superficial skin cancers. And to put it into context, about 100,000 men were diagnosed with cancer in Canada in 2017, and about 1/5 of them were diagnosed with prostate cancer. So it's very, very common. And this graph just shows the incidence or the occurrence rates for the common cancers. And so the black line there shows prostate cancer incidence rates, and that's over time. And then the blue line shows the other common cancers, lung cancer, colorectal cancer, and bladder cancer. And you can see that, for starters, prostate cancer is certainly more common than the other cancers in men. And what you also see is over time, the incidence has changed. So if you go back into the late 80s, the incidence was lower, and then sort of in the early 90s, we saw a peak in the incidence of prostate cancer, just right around here. And it's not that more people were getting prostate cancer, but that peak occurred because of the onset of PSA testing. And so I'm sure most of you are familiar with the PSA test, and that's when it became widely used and started being used to pick up cancers earlier and to pick up more cancers. And so that's why that peak occurred. And then things sort of leveled off for a time, and then we saw a second peak there in the late 90s, early 2000s, and that again corresponds to a second wave of intense screening, more intense screening with PSA. And then since then, things have sort of leveled off, and actually in recent years, the incidence of prostate cancer has been coming down, and we think that most likely is a result of less screening. You know, in recent years, there's been less recommendation in terms of PSA screening and the screening guidelines by the various cancer organizations in North America for many reasons. Prostate cancer is also, unfortunately, a major cause of death in men. It's the 3rd most common cause of cancer death in men. And if we look back in 2017, about 40,000 men died of cancer in 2017 in Canada, and about 4,000 of them died of prostate cancer. So again, a very significant cause of death. And this graph shows the mortality rate of the same four cancers, and you see that actually the cancer with the highest mortality rate in men is lung cancer. That's the top blue line, and then the colon cancer and prostate cancer are the lower lines. And you know, the good news we see is that actually in recent years the mortality rate from prostate cancer has been decreasing. If you kind of look from 1992 onwards, 2016, there has been a decrease in the mortality rate. We don't know exactly why that is. Probably some of that relates to PSA screening, picking up cancer earlier, and effective treatments that can be given at earlier stages, and probably also related to better systemic treatment, so medicines, more use of hormone therapy and some of the newer medicines that are out there. Now, the other good news is that prostate cancer that's localized, so prostate cancer that hasn't spread, is potentially curable. And there are a number of effective treatment options available for men with these potentially curable prostate cancers. And so these are the four sort of standard treatment options or management options for prostate cancer. There are others that, which I'll mention afterwards, but these days, sort of the four standards would include active surveillance, and so that's an option where, for some men, where it's deemed that their cancer may not be a risk to their life at that point in time, and so the decision is made to watch the cancer and apply treatment at a later date when and if the cancer is deemed to be a potential threat to life or a potential issue. And that's a great option for many men, particularly men with lower risk kinds of cancers. And more these days we're recommending that for men when we feel it's safe, for sure. Another option would be surgery, or what we call radical prostatectomy. Very time-tested treatment, probably one of the more common treatments used for prostate cancer, and that can be done in a number of different ways, either open prostatectomy, laparoscopic, or robotic prostatectomy. Third option would be brachytherapy. So brachytherapy is where we implant radioactive sources into the prostate gland to try and basically treating the gland with radiation from the inside of it. And then the final option is what we call external beam radiation treatment, and that's the bulk of what I'm going to talk about today. As I mentioned, there are other options out there that would be considered sort of non-standard options, such as cryotherapy or freezing the gland, or HIFU, which would be a high-intensity focused ultrasound, and those are available at certain centers as well. But most of what I'm going to talk about is external beam radiation treatment. So what external beam radiation treatment is when we use an external source of ionizing radiation to deliver treatment to the prostate gland. And this is just a picture of one of our radiation machines we have at the Victoria Center. We name all our machines after trees, so this is the oak, the name of that machine. So external all the four options that I mentioned there, or the three treatment options that I mentioned there, are great options, and they each have their advantages and their disadvantages, but they're all good treatment options for men with prostate cancer. These are the advantages and disadvantages that we see for external radiation treatments. And on the advantages side, I think probably one of the biggest advantages of the external treatments is it's non-invasive. The other options, surgery or brachytherapy, are both to a certain degree invasive. External radiation doesn't require any hospital stay. Generally speaking, patients with external beam radiation treatments don't require a catheter to be placed into the urethra, into the bladder. And on the whole, I mean, there are exceptions, but on the whole, the acute toxicity, or the side effects that men experience sort of during the treatment and shortly thereafter, tends to be relatively low. Most men tolerate radiation treatment, external radiation treatment, very, very well. And some of that has to do with some of the technological advances that we'll talk about. And the other thing is, it's applicable to most men. I mean, this is an option for most men. There are certain disorders and certain issues, health issues, that can exclude someone from having external treatment, but they're not frequent. For the most part, this is a treatment that's applicable to most men despite age or other health issues, whereas that's not necessarily the case for, say, surgery or brachytherapy. To have surgery, for example, your other health status, things like history of heart problems or other issues can really play into whether it's an option for you, and age to a certain extent, which is kind of less so with the external radiation treatments. It does have a number of disadvantages, though, and probably the biggest disadvantage is convenience. As you'll see on some of the following slides, external radiation treatment, unlike surgery and radiotherapy, involves a protracted course of treatment. Most men come in, a course of external radiation treatment generally lasts between 20 to 40 radiation treatments, depending on which schedule is used, and it's typically one treatment a day, Monday to Friday. So most men are coming in for daily for 4 to 8 weeks, depending on how it's prescribed. And then in the long run, as with any treatment, some patients can have long-term problems. There is a minority of patients that can have long-term or chronic problems with the bladder. And in particular, there are some men who can have chronic or long-term problems with the bowels or the rectum. And that's what I'm going to talk a lot more. Most of the rest of the talk tonight has to do with how we can mitigate some of those long-term bowel side effects, or side effects that have to do with the rectum. So basically, radiation treatment can cause what we call rectal toxicity, or long-term side effects, or short-term and long-term side effects to do with the bowel, or the lower bowel of the rectum. And the thing about radiation treatment, it's a balance. The more radiation treatment that we can, the more radiation that we can deliver to the prostate gland, the higher the chance of controlling the disease. We know that. If we give enough radiation, we can eliminate cancer cells. But we have to do that without harming the patient. Because the rectum, or the lower intestine, the rectum sits right near the prostate gland, the risk of causing long-term bowel troubles is what limits the dose of radiation that we can safely deliver for prostate cancer. So it's a balance. On one hand, we want to give as much radiation as we can to the prostate. On the other hand, we want to minimize the amount of radiation that we give to the bowel, because that's the side effect that's going to limit what we can, is going to limit the amount of radiation we can give. That's the side effect that can harm people. And it can be quite, some long-term side effects can be difficult for men. Long-term radiation-induced rectal side effects can include symptoms such as pain, rectal pain, bleeding, passage of mucus in the stool, chronic diarrhea, loss of control of defecation, so fecal leakage, ulceration, fistula, which is holes can form between the bowel and the skin, or between the bowel and the bladder, or an obstruction. It's possible for some people who have radiation treatment to have the bowels block off, which could require surgery. And in the extreme, which is luckily it's very, very rare, but in the extreme, radiation-induced bowel damage can even result in a colostomy, or very rarely death. These things are possible. And so we want to do everything we can to try and minimize these risks. And these are just a few pictures. Fortunately, this isn't something that we see very often. These are colonoscopy pictures of the rectum. And on this side, we see the arrows kind of pointing at an ulcer that was caused by radiation. An ulcer is kind of like a scrape that doesn't heal properly in the lining of the intestine, and that can bleed or cause some discomfort. And then here we see a kind of a more extensive picture of someone's bowels that has radiation-induced damage, radiation-induced ulceration. Again, I want to stress that these situations are not common, but this is something that can happen, and we want to minimize this as much as possible. And here's another long-term problem that can sometimes happen. The radiation in some men can cause the blood vessels in the lining of the intestine to get kind of fragile, and then those blood vessels can bleed a little bit. So this is an example of someone who's now prone to bleeding from the bowel as a consequence of radiation. So there are a number of methods that we can use to try and minimize these risks minimize the risk of long-term side effects. And so these are kind of the four kind of major ways that we use in the clinic to try and keep those risks of causing those damages that I just showed you in the pictures as low as possible. And I'll go through each of these ones in detail, but the first way that radiation oncologists have minimized side effects and long-term side effects is through fractionation. And what fractionation means is breaking the radiation dose up into a number of small doses. By giving a whole bunch of small doses of radiation rather than a small number of big doses, we reduce the risk of long-term side effects, and we'll get into that a bit more. The other important way that we reduce side effects is through technology. With time, we've developed more and more advanced ways of delivering radiation, more advanced ways of focusing the radiation so that it's, the bulk of the high dose radiation goes to the prostate and little of it goes to the neighboring organs like the rectum and the prostate. And the better we get at that, the better our technology gets, the less long-term side effects we can get. The third way that we reduce side effects with radiation treatment is through what's called image-guided radiation treatment, or image guidance. And what this is applying techniques each day when a man is getting his radiation treatment to try and aim the radiation more accurately each day, so that we're hitting the prostate and not hitting the bowel or the bladder or things that are nearby. And then the newest thing that we have to try and minimize side effects with prostate cancer is this product, this gel, and it's a product called Space OAR Hydrogel. And what this is and I'll get into this in more detail, but in a nutshell, it's a gel that's injected between the prostate and the rectum to create some space between the two organs. And what that does is allows us to reduce the amount of radiation that the rectum receives, and so people get less side effects in the long run. So I'll go through those each one in detail. So this is fractionation. So if you've ever wondered why courses of radiation treatment are so long, why people have to come in for 20 treatments, 30 treatments, 40 treatments, this is why. Basically, what this shows is it's a graph showing two curves, and basically what it's showing is the amount of damage that a single dose of radiation causes on this curve here. This curve is normal cells, so let's say the normal cells of the rectum or the bowel or the bladder, and then the other curve is how much damage a single dose of radiation causes on tumor cells. So if you say we give a big dose of radiation, where my arrow is, we give a large dose of radiation straight down, we're causing more damage to the normal cells than we are to the tumor cells, which is not good. That's not the way we want to do things. Whereas if we give, say, a really small dose of radiation, then we're causing more damage to the tumor cells, this curve here, than we are to the normal cells. And so in a nutshell, this is why we give a bunch of small doses. By giving a whole lot of really small doses of radiation, we're taking advantage of this little differential here where we're killing more tumor cells than we are damaging the normal cells. And so by repeating the small dose again and again, we're making that differential bigger and bigger and bigger, rather than the reverse, causing more damage to the normal cells. So this is the kind of the original way the radiation oncologists devised to try and minimize people's side effects. And we do this with all kinds of radiation treatments at all different sites. But this is one of the really important bases of radiation treatment to minimize side effects. So that's why radiation treatment is so inconvenient. And then, as I mentioned, the second way that we reduce side effects with radiation treatment is through technology. As technology improves, radiation planning and delivery techniques improve, and so we're able to deliver the treatment in a more focused manner. When I was training, for radiation oncology in sort of the early 2000s, the techniques that we used were far different. We used we used a technique of radiation that was called 3D conformal radiation treatment. So it was used far inferior computer technology, far inferior imaging technology, far inferior treatment machines and delivery technology to give the radiation treatment. And so we weren't able to focus or conform the radiation dose to where we wanted it to go as well as we can now. Since that time, there's been a number of rapid improvement actually in technology, and again, basically because of improvements in computer technology, imaging technology, and radiation delivery techniques. Now the standard techniques to deliver radiation. You might have heard of these acronyms. IMRT or VMAT are considered the current standard. And basically, these techniques, in a nutshell, are just able to conform the dose to the prostate gland better in reducing the dose of radiation to the organs. So this kind of illustrates it. So on this side here, both of them, what these are CAT scan pictures. So this is a person in cross-section. And so up here is the front of the person, back here is their back, this is the right side, this is the left side, this white bone here is the hip, this is the other hip, and the prostate gland is this little red circle in the middle, and behind the prostate gland is the rectum. And this color wash that you're seeing is the radiation dose. The hotter, the redder the color, the hotter the radiation dose, the bluer the color, the colder it is. So this is using kind of what the older technology that I mentioned that we used when I was training. And as you can see, the high dose of radiation is where it's red. There's a lot of tissue outside of the prostate. This here is the prostate gland. There's all this tissue outside of the prostate gland that's still getting a high dose of radiation. And in particular, this structure here, this circle here, that's the rectum. Basically, the entire rectum here is getting a high dose of radiation. And that was just a limitation of the technology at the time. Nowadays, we would use this technique. So this is what we call IMRT, one of the more advanced techniques. And you can see the difference here. Now you see this red color here is basically just on the hot area radiation. It's basically just where the prostate gland is. We're seeing a lot more green and blue in the area outside the prostate. So basically the dose of radiation is now conformed more tightly to where we want it, and there's a lot less radiation in areas that we don't want, like the rectum. And so by using these new techniques, these new, what we use now, IMRT or VMAT, we're able to reduce the high dose of radiation to the structures nearby, in this case the rectum, and actually that results in about 25% less long-term side effects with bowel. So this was a major improvement, which came around, early 2000s, early to mid 2000s. So men have much less long-term problems than they did before, but despite the use of this more advanced technology, we still see that there's about 15% of men that have significant sort of long-term bowel troubles. And when I say grade 2 plus bowel toxicity, that means side effects that are noticeable, side effects that at the minimum are noticeable for men and troublesome for men, and at the extreme can be, potentially can be very troublesome for men or require, surgery and things like that. So there are a significant number of men who still, with these advanced techniques, still have, significant bowel troubles. So we need to reduce them more. And so here's another way we do that. And the third way that we reduce side effects is by using this, what I mentioned before, this image-guided radiotherapy. And what this is this is using imaging techniques that are applied every day while the patient is on the treatment table to better aim the radiation, to make sure that the radiation is being delivered accurately to the prostate gland. And there's different ways that we do that. So one way that we do it, for example, is we use what's called fiducial markers. And so what we'll do is we'll put little seeds, you can see them on this x-ray picture, we'll put little seeds, these little white guys here, into the prostate gland. And that way, when the patient is lying on the table each day, we'll take a picture of the pelvis, we can see the seeds, and that way we can kind of aim the beam, at the seeds, better. We can give us a better idea of where exactly the prostate gland is on that given day. And it kind of helps us to make sure we're hitting the target gland. That's one way we can do it. Another way we can do it is by using CAT scans. Our fancy radiation machines these days aren't just radiation delivery machines. They also have a CAT scan device attached to the machine as well that can scan the patient, and then we can move them around to make sure they're in the right place. And all these methods, whichever, there's different ways that you can do image guidance. There's really high-tech stuff. Some places, instead of putting in little seeds like this, they'll put in little transponders that actually communicate with the radiation machine and tell the radiation machine where the prostate is so that it doesn't ever miss. There's all sorts of different ways of doing this image guidance in 2019, but whichever way you use, they've all been shown to further decrease the side effects of treatment, improve disease control, and reduce the long-term bowel side effects that I mentioned. But finally, the last way I was going to talk about is this Space OAR Hydrogel. And what this is the newest addition to our arsenal of options that we use to decrease the bowel side effects of radiation treatment. And what this is it's a polyethylene glycol based polymer. So polyethylene glycol, PEG, is basically just that stuff that powder that we give to kids for constipation. This company has used a polymer based on this substance, polyethylene glycol, which basically makes it into a gel, and it's placed between the rectum and the prostate for the purpose of reducing the side effects of radiation treatment. And so this slide just kind of illustrates why we get bowel side effects from radiation treatment. If this is the prostate gland here, and as I mentioned before, the rectum sits right against it. And when we give radiation treatment, we know that it's not perfect. You know, we can't just give the radiation to the prostate or else we'll miss. We have to add a little bit of a safety margin to make sure we hit the target every day. It's not a big margin, but a little margin. So that means that the high dose of radiation is this kind of red cloud here, which always is going to overlap at least a little bit with the rectum. So the front wall of the rectum is always going to get some radiation, and that kind of sunburn that you get on the front wall of the rectum is what leads to side effects in the short run and in the long term. So with this product, this gel, it's injected in between. Basically, it's not rocket science. It's a very simple solution. Basically, all it's doing is moving the prostate away from the rectum. So now you see things have changed. Now, because of that space that's created, this high dose of radiation is no longer overlapping with the rectum anymore. Now it's just going through the gel. So the rectum is free from high dose radiation, and so a person gets less side effects in the long run. How much space is needed? Well, with proper placement of this gel, it creates that space that we see there is about 1 centimeter or 1.5 centimeters. So it's about that much, which doesn't seem like a lot of space, but with our modern sort of highly conformal, highly focused radiation planning and delivery techniques, that's enough space to really reduce the amount of radiation that the bowels get, that the rectum gets by a lot. And this is a real example of I think this is the first patient that we did. On this side, you can see the red line here, the circle, that's kind of the area that we want to treat. And this brown circle here is the rectum. This is before the gel was instilled. And so if we had treated him then, this green here would have been the area that overlapped with the rectum. So all this rectum here and the green here would have gotten radiation. Whereas we put this gel in, which is the yellow, now the rectum's moved completely out. It's completely away from the high dose of radiation. So this particular patient, sailed through treatment basically without any diarrhea, without any bowel troubles, and it's been about 1.5 years, and he's still doing great without any long-term issues. Inserting this gel, it's not as simple. It's straightforward, but it is a little bit tricky, and does take a little bit of practice. It's an outpatient procedure, so people come in. It takes about maybe 20-25 minutes to put in this gel. It's done under a local anesthetic. Basically, there's a ultrasound probe that's placed in the rectum, so that's SC, where the prostate gland is. And we stick this. We freeze the skin, and we put this needle in, and we have to get the needle into this very little space that's between the prostate gland and the rectum. And once the needle's there, you inject this gel in, and basically it's two syringes injected at the same time. One has the polyethylene glycol, and one has an accelerant. And when the two touch, they immediately form a hard gel. And so you inject them in at the same time, and when they get injected, they form this kind of firm gel that creates this space. It's a little bit tricky, but with practice, we've gotten pretty good at it. And then here's a patient that's an example of a patient with MRI. So this is him before. So here's the prostate gland, and here's the rectum. We inject the spacer, so this is after application. And so you can see it's about 1 centimeter or 1.5 centimeters. And then the gel, did you have a question?
Carry on, you might answer it.
and then the gel disappears. That's what you're
that's
asking.
my question.
So it begins to dissolve after 3 months, and it is gone by 12 months. So did you have a question?
Well, so when you inject it
Yep.
in there, do you routinely take a picture to see that it's in place before you start it?
Yeah, it's true, and
Make sure
we
it's
do.
working.
So, at the time that we inject it, I can see it. So I've got an ultrasound picture in front of me, so I can see, basically what I can see is this sort of a thing. And so I can actually see on my screen when I inject it if it's injected appropriately and it's in the right place and all that kind of stuff. And then we do another scan afterwards. That's kind of like one of these scans that we use for planning radiation treatment, so we can see it come up. It does add a little bit because we do need to do it. The gel doesn't show up great. As you can see here, it's showing up on this CAT scan because I've drawn a yellow thing around it, but really it doesn't show up on CAT scans. So every patient who has the gel has to get an MRI scan because it shows up clearly on an MRI scan. That make sense? So yeah, so the gel doesn't hang around. It's biodegradable. The body just absorbs it. It's mostly water, really, to be honest. It's just a water and a polymer matrix. So it disappears. And men say that they can, when we inject it, they can feel it a little bit for a few minutes, and then they don't notice it there anymore after that. And it's no one's ever mentioned that it's uncomfortable, and we've asked repeatedly. So this is the study that was done. So this is the kind of some of the data from the pivotal study that showed that this stuff is beneficial. And what it shows, and what this graph shows, is that the red line are the percentage of people who did not have spacer gel put in place and had radiation treatment. And the blue line down here, this flat line, are people who did have the gel present. And what this is showing is the percentage of people who had long-term, difficult side effects with the bowels. And getting back to what I said originally, even without the gel, there's not a lot of people, with our modern techniques, there's not a lot of people that are having long-term problems. Only 6% of people were having troublesome issues in the long run because the study, they used all the other 3 techniques that I mentioned. But the difference you can see is that 0 were having troublesome side effects in the long run when they had the gel in place. So, some people argue, well, do we really need it? Because 6% of people having bad long-term side effects isn't very many to start with. But my argument would be, well, 0 is a lot better, and so, I think certainly, I personally believe it's worthwhile. This graph is similar. It shows the quality of life. So what they ask men, a lot of questions to get an idea of what their quality of life around the bowels are. And so the blue line again is people with the gel, and the red is people who didn't have the gel. And you see for both groups during the radiation treatment, their bowel quality of life drops because both groups do get some side effects during the treatment. But then after the treatments are done, you see the red line, the people who didn't get any of the gel, their quality of life kind of remains lower than baseline than what it started with in the long run. It never really recovers. Whereas the people who had the gel, they bounce right back after the treatment's done, and their quality of life in the long run goes back to the way it was before they had treatment. And so I think that kind of tells it all. I mean, we can talk about grades of side effects and things like that, but at the end of the day, important things are you cured your cancer, and what's your quality of life like? Those are the 2 important things. And this slide, I think, says it all that way. Quality of life goes back to the way it was when we started. I think that's important. And then strangely enough, for some reason, the gel seems to help with the bladder side effects too. And we don't know why. This was a big study that was done to compare this, and it was a very well-conducted study. And for some reason on the study, the patients that had the gel were 4 times less likely to have long-term problems with leakiness of the bladder. It's not designed to help that. We don't really know why. Maybe the placement of it has some effect on the doses to some important parts of the urinary tract that we don't quite understand yet, but it seems to help with urinary flow after radiation treatment as well. So, as I mentioned before, we now have a program here in Victoria, actually just in Victoria, is where the program is, and this came about, partially thanks to the Allen Prostate Center, because it's an expensive product. It's not cheap, and so there's no funding for this product to start with. And so when we wanted to start using it, we approached the Prostate Center to see if they would help us out. And with their help and some money from elsewhere, we were able to procure product to pilot it in 20 patients, which went really, really well. And we were able to use the data from those 20 patients to kind of lobby the agency for more funding. And at this point, the cancer agency has actually extended, they're willing to fund it, they've extended funding for the gel for about 50 cases a year for the next 3 years. So it's a bit of a pilot program. So we've got enough funding to do about somewhere between 120 to 150 cases. And then we hope that if we're able to demonstrate its utility in these in this group of men, we're confident we'll be able to secure more funding after that. And actually, our team was recognized just at the end of the year by the Cancer Agency with a BC Cancer Agency Excellence Award for Innovation and Discovery for its use in the program. So that was great too. And I think that's important because that helps to kind of shine a bit more light on this program, and I think hopefully in the long run should help us secure more long-term funding to use it. Incidentally, I think BC is the only place in Canada that's publicly funding the use of this product right now. And so this is all the team members. There's the 3 physicians here, myself, Dr. Goulart, Dr. Pai, the nursing staff, Heather Dixon, Michelle Brown, Claire Sutton, Michelle Lafreniere, radiation therapy department was Fraser Jensen and Kathy Lacey, and then the radiation treatment booking clerk, Michelle Sankey, that keeps everything moving. So that's where we're at now. In terms of future directions, we want to do more with this. We want to continue, we want to increase our use of this product in the external beam radiation patients that we treat standardly. We also want to evaluate its role in some other situations. There's a potential role for this gel in patients who get other types of radiation treatments, so say brachytherapy. There's no reason why it wouldn't benefit men to have the brachytherapy seeds put in place. The other thing is to evaluate the role in other cancers. There are other pelvic cancers where this could be useful. An example would be cervical cancer in women. The cervix is in a similar position in the pelvis as the prostate is, and women who are treated with cervix cancer have a lot of the same long-term bowel troubles that men who are treated with prostate cancer get. And so there's certainly a possibility of using this kind of a product to reduce side effects in women with cervix cancer. And then we're trying to put together a number of different research projects. A few of them are to try and see if there's ways we can predict beforehand who's going to benefit more from this product and who's going to benefit less. I think that sort of research is important in a system where funding is limited. We want to be able to get the most bang out of our buck and who we use it for. This will give us a chance to try out some other techniques in terms of radiation dose escalation. Now that we can move the rectum out of the way, we can start playing by trying to jack up the dose of radiation and see if we can increase our cure rates without increasing the side effects, and try and do some sort of physicsy type stuff, see what kind of radiation planning techniques maximize the use of the gel. So there's a lot of stuff going on in this area, in this field. So that's all I had. Did you guys have any questions? Yeah.
2 questions. First, is there an application of this gel technique to prostatectomy?
That's a good question, actually, and that's another one of the areas that we want to look at. I know that this product is used in the States a lot more widely because it's a for-profit system, and so I do know that there are at least a couple of oncologists that have used it in the States in that situation. So it can be. I know in theory it can be done. I do know a few patients that have had it placed. It's not one of the official indications for the product. It would be considered an off-label use, I think, at this point in time. And there's no studies that have been done, but it is certainly possible. It would probably be a little bit more difficult. We tossed around the idea of trying it. It would probably be more difficult because that space between the prostate and the rectum, if you've had surgery, that space in front of the rectum, there's probably some more scar tissue and stuff there that may make it more difficult. But it certainly would be a potential idea.
I see. My second question is, you haven't addressed the effect of this, if any, on erectile dysfunction. Is there any?
Yeah, and so that's another one. I didn't put that up, but actually, just like in the same vein as it I mentioned that for some reason that we don't understand, it decreases the bladder issues in the long run. The most recent data from that same large study, for some reason it seems to, that data shows that for some reason it reduces the rate of erectile dysfunction. Again, we don't know exactly why, but it does.
Thank you.
Are there any contraindications to its use?
So the one contraindication, and that's a good question, and we've tossed that around too. The one thing we worry about, nobody really knows, but the one thing we do worry about is if you have cancer that's extending outside of the gland, it can extend outside of the gland in different directions. It could extend this way, which would be fine. It could extend this way, would be fine. But if it extends outside the gland backwards towards the rectum, then we would worry that we might push some of the cancer cells away from the prostate and away from the radiation. So extra prostatic extension in the area of the rectum would be a potential area of concern. That being said, the truth is most people who would have that, we would probably put them on hormone therapy, which would kind of shrink things anyway, so it may or may not be a concern.
And another question just about general prostate radiation. If one has like lower bowel, like colitis or Crohn's or irritable bowel syndrome, does that make their symptoms worse?
It can. So inflammatory bowel disorder. So I mentioned that most people can have radiation for prostate, external radiation, but there's very few people who can't have it. Inflammatory bowel disease, or IBD, so that's Crohn's disease and ulcerative colitis. Those are two conditions that that seem to not mix well with radiation. There's some studies out there that people do fine, but there's certainly some studies that have shown that people that have ulcerative colitis or Crohn's disease can have much higher rates of bad side effects. And I know in my experience, with people I know or other radiation oncologists, or hearing of horror stories, the patients that I've heard of that have had really bad side effects from radiation even have often been people with inflammatory bowel disease or Crohn's disease. Crohn's disease or ulcerative colitis. So that being said, this product allows us to potentially treat those people. Yeah. And actually, in the first batch of 5 people that we treated was one man who didn't have a whole lot of other options for various reasons, but did have ulcerative colitis, and so we thought, okay, well, let's try it with the gel, and that seems to be a good for him. So that's one of the official indications. When the BC Cancer Agency said they'd give us money to buy it, one of the indications was we were supposed to use it for men who have ulcerative colitis or Crohn's disease who couldn't otherwise have radiation treatment.
That's great.
Yeah, it's good. Sorry, I'll go.
Well, I just wondered, the prostate, this gel can go between the rectum and the backside of the prostate.
Mm-hmm.
Is there sort of a capsule around the prostate? Is there any way to sort of surround the whole prostate with the gel and protect the bladder?
Yeah.
Just sap the place?
Yeah, you wonder if you could.
what stops it?
And it's funny you say that, because they're actually looking at it for other cancers, like pancreas cancer, for example, is a notorious one where there's a whole lot of important things near the pancreas that make radiation difficult. So they are looking at using this product or a slightly different version of this product to try and move everything out of the way of the pancreas. So they're looking at these sorts of things for sure.
But yeah, is there a space around the prostate, like an interstitial or like a capsule or something?
There is. The prostate's surrounding the capsule, so in theory it would be possible to get gel in other places. You certainly could. Yeah.
It seems to me that there could be real quality. The rectum is right up against the prostate.
Mm-hmm.
And you insert a needle to make sure it goes between them and insert. If you by accident penetrated the rectum wall, you could insert it into the rectum, which wouldn't be a good thing.
And that's the worry. That's what makes us sweat when we're putting it in. Definitely that's the concern, because that space is very small. And that's why I said it's a bit tricky and it takes some practice. And probably is best done by people who are experienced in brachytherapy. And that's what the 3 of us who do it are all brachytherapy people, because that's what brachytherapy is all about, is putting needles into that area. But you're right, it's tricky, and that can happen. One thing that can happen is you can put the gel, as you said, into the, let me get a good picture of it. You could put the gel into the rectal wall, in which case you're pushing the rectum closer to the prostate gland. And so the concern about that is, so in that situation, if that happens, so that has happened to people in the past. It's never happened with us. We've never had that happen. But talking to the people in the company that provides this gel, in general, in other places like in the States and stuff, it has happened to a small number of people. In that situation, no one's ever been harmed by it, but what you do need to do is wait for the gel to dissolve before delivering the patient. So if that were to happen, you would probably, either wait 6 months until the gel's gone. Between 3 and 6 months until the gel's gone, and then treat. And if the person couldn't wait, you'd have to put them on medicines to kind of temporize things. But that's a concern. The other concern is injecting it into the blood vessels, because there are blood vessels around here that you could get the gel into, and that's happened to people as well. There have been documented cases of intravascular or intra-blood vessel injection of this gel, and again, fortunately, no one's been harmed by it, but it has happened.
Is an MRI ever used for guidance on this?
Not for
like
guidance.
a biopsy?
The reason MRI is done for confirmation, so we definitely get an MRI after it's done. But the problem is you can't do it for guidance because it's hard. You could in theory, so it's supposed to be possible. But ultrasound is what really lends itself to this kind of procedure. Because ultrasound is a real-time imaging technique. Like an MRI, you put someone in a scanner, you scan them, and then you get the picture. Whereas with ultrasound, I'm getting the picture while I'm putting the needles in. So it's sort of a real-time method of doing it, so that's why ultrasound is the preferred way of doing it.
Have any follow-up studies been done to determine if people who are suffering bladder and bowel incontinence will ever regain normalcy?
So yeah, people have looked at that. Generally speaking, if someone has bad enough radiation side effects that it causes a urinary incontinence, which is not common, but it can happen, it's not something that generally gets a lot better with time. Similarly, people who have severe enough damage to the anal sphincter to cause bowel incontinence, that's probably not going to get better with time, unfortunately. That being said, there are medical procedures that can be done to help those things. So for example, with the bladder, if someone's getting incontinence from either surgery or radiation treatments, there are procedures that can be done, a sling procedure or an artificial sphincter that can be done to help with that. And similarly, there may be procedures that can be done to help with bowel incontinence as well. Yep.
So would this be able to be done if somebody had already started with radiation and was having bad side effects? Or is it better to do it?
You'd have to do it beforehand, yeah, you'd have to, because you wouldn't really, it's a good question, but the radiation side effects usually happen, they're cumulative. So, in a course of radiation treatment, you're not really going to, if you're going to get bad side effects, it's going to happen near the tail end when the time is already passed. So if you're going to do it, it's probably best to do it beforehand.
Just curious, is anatomically, is everybody built pretty much the same, and that space is always very, very small, or are there some men where it's a better treatment to really push for this versus others?
So that's what we're trying to figure out. Certainly, having seen 30 or 40 of these sort of cases, certainly there's variation. That space in some men is tiny, 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 and very hard to get a needle in. In some men, it's bigger, and certainly. So whether if there's some men who already just intrinsically are born with a bit of a space there are some men, and so that's why I was mentioning that's one of the research projects that we're working on we're going through it and looking at men before the gel and after the gel to see, and doing that for a whole bunch of men to see is there some certain men who have or who just are built that way that they already have a bit of a space that they don't even need the gel, and if so, maybe those guys don't, we wouldn't steer them in this direction, or is there a cutoff, like if that space is naturally whatever 4 millimeters or less, then you really need to have it. That's the kind of stuff that we're looking for. But certainly there is variation in that space, and that variation makes it easier or harder to put the gel in the first place as well. Sure.
You said that that it's quite a expensive procedure. Is that because of price of the material?
Yeah, it's the price of the material, and I mean, it's all relative. I mean, the price of the product in Canada is roughly $3,000 per person, which, in the grand scheme of things isn't all that expensive, for us, our radiation program and the way the funding is done, it's a hardship to get. But in context, if you put that in context with, a lot of the chemotherapy drugs, or even more so, a lot of the immune therapy drugs that we're using these days, it's actually very little amount of money. So, it's all relative, but it's expensive enough that it does make it, difficult to get money for it.
Would one ever have the option to pay out of pocket and say, hey, I'll fund my own?
I was wondering about that today, actually. I was thinking about that. Like, certainly that's how it's done in other places. Whether we'd be able to get away with that in BC, I'm not entirely certain. It will come up at some point. Someone's going to ask, and when we don't have it, and it'll come up, and we'll have to ask us if we're allowed to do that. I really don't know. I mean, I start to wonder, does that count as a two-tiered system? Or something? I don't know the answer to that. It will come up. I hope someone else comes up for it. Great. Thank you very much.
Okay.
Thank you.